Hello everyone, we are back with the CTEV discussion part 2. Be sure to log in and watch my part 1 video regarding the basics and the diagnosis of CTEV condition before you join this one. So for the management plan of the CTEV, there can always be a non-operative and operative methods. We'll first go over to the non-operative methods. The indications for this type of treatment is definitely a first and foremost line because most cases of CTEV can be managed very well using non-operative modalities. And the modalities that is include is the serial manipulation and casting method. Usually there are several types of treatment that could be used to mold the foot into the wanted position or the normal position, and that includes the famous Ponseti method that is known worldwide. There is also the French method. Although there are many other methods that has been known in this world, you could always pick one or two methods that suits you the best and also has the best evidence-based success rate. And here I will elaborate more about the French method and the Ponseti method. So for the French method, basically it is divided into a correction phase and also the maintenance phase. During the correction phase, the daily corrective manipulations are performed, and next the corrections that are achieved through the passive manipulation is being maintained by using a specific method. Usually, the therapist will perform taping to achieve or to maintain the correction, and gradual correction is being done through direct distraction, derotation, and also correction of the hindfoot valgus. And this method is quite difficult because you need to be trained well before you could do the correction well. And next, the correction is usually maintained with tapes as opposed to cast that is usually done in patients with Ponseti method. The next method that I would like to elaborate more is the Ponseti method, and there are several basic questions that needs to be answered before you can fully understand the Ponseti. The first is when do you start to do a Ponseti method? The best time would actually be around 7 to 10 days because some authors mention that the baby's skin that has just being born out of the womb is usually too prone to irritations, and therefore at around 7 to 10 days the risk of skin irritation has decreased, and also the foot deformity is very clearly pathological and needs treatment. The next would be when it is very effective. Casting and manipulation and casting is usually very effective if the child is not yet walking, and it is still effective if the child has just started walking and up to several years. You need to remember that operative surgery is usually done when non-operative treatment has failed, and in developing countries sometimes children present to us with CTEV after the children has walked several years, and it is sometimes still advisable to try and do the manipulation and casting and move on to the operation if the foot is too stiff to accept any changes. The next question comes is how do you do the Ponseti? There are actually 4 basic steps for the Ponseti method, which includes manipulation, casting, Achilles tenotomy if needed, and finally bracing. We'll go through each of it right now. Starting from the manipulation, there are certain things that you should never do while manipulating a foot, which includes pronation, touching the heel, and using force. Even though the deformity consists of a supination type of deformity, pronation is not advised because the foot is actually derotated from its normal position, and what you are trying to do is derotating the whole foot as a block. And you do that by using talus as the axis of the manipulation. We could see here in this picture, this is a manipulation, and you could see here that the examiner uses the thumb here to use as an axis of rotation for the whole foot to move outwards. Okay, and next I will explain more about how to do the casting later on. Now for the duration, you usually need to manipulate the leg for several minutes. For the young and non-walking patient, you need to hold the foot in a position that you want for around 30 to 40 seconds, and then you release the foot and you repeat it 1 to 2 times. For older patient, you need to hold it longer and repeat it even more frequently, 3 to 4 times at least for each foot. Afterwards, you need at least a time of 2 minutes per foot if the child is not walking, and if it is already walking, you need at least 5 to 10 minutes for each foot. Now, talking about the technique, you need to know that the basic principles of CTEV include stabilizing the talus or using the talus as the axis of the derotation. The next is the foot manipulation, in which the supination and abduction is being performed. Next is to hold the pressure, release the pressure, and repeat them. That is the basic technique of foot manipulation. Remember, once again, you need to use the talus as the axis and manipulate the foot by doing an abduction motion, and you need to hold the pressure and release, then repeat the whole thing. 1 to 2 times for non-walking, 3 to 4 times for patients who are already walking. Now, once you have done the manipulation, next comes the cast. There are certain basics for the casting and certain techniques for it. For the young and non-walking, usually you need to cast the knee also in 90 degree of flexion to decrease the tensions of certain muscles that goes through 2 joints. And then you need to change the cast every 5 to 7 days. And usually the last cast will have a longer period, which is 3 weeks. If the patient is already walking, then the knee can be held in a slightly reduced flexion of 70 degrees. The cast should be changed at every 7 to 10 days, and the last cast should last for at least 4 weeks. Now, the reason behind the less degree of flexion of the knee, because the patient is advised to stand up and continue walking with their cast placed in, and this degree of flexion allows the child to stand up. Now, the thing about casting is that there are techniques that you need to remember so that the cast can move on from one cast to another in a smooth way. And the first cast should always allow correction of the cavus, but at the same time, the heel inversion and heel varus is also gradually corrected. So for the first manipulation is you are trying to correct the cavus. You could see here that the cavus is our main focus, and the way to do that is that you need to elevate the first ray and achieve a homogeneous supination of the whole forefoot. You do that by applying pressure from underneath the foot to the heads of the metatarsal, or some would say to elevate the first metatarsal or elevate the first ray. At first, after the casting, the foot will appear even worse because it is even supinated. But what you are trying to do here is you want to achieve the alignment of the forefoot to those of the midfoot and hindfoot. And after gaining those good alignment, you could see here, okay, this is the technique. You stabilize the talus and you elevate the first ray or first metatarsal. The goal is to achieve a forefoot that is in line with the midfoot. After you have achieved this through the cast, then for the next casting, what you want to do is you want to correct the heel, varus, and also inversion. And in here, you also try to correct the cavus. And the technique to do that is that you need to stabilize the talus and you need to hold the foot in abduction with appropriate amount of supination. You could see here that the foot is gradually corrected. One finger holds the talus and the other hand brings the whole foot in abduction with appropriate degree of supination. Now, the goals that you need to do is to cast as often as needed. You may not force a foot into the wanted position. You should always try to feel how much change that you are putting in the baby's foot. You should not cast as little as needed. Instead, you should cast as often as needed to achieve these goals. In young non-walking patient, you should try to achieve at least 50 to 60 degrees of abduction, and you should try to achieve a neutral heel. In the case of neutral heel, it means that the heel is at least in a neutral position, but if the heel can achieve a valgus position, then it is good. For older walking patient, you need less degree of abduction, which is around 30 to 50 degree of abduction. Once again, how to measure these degrees? You need to use various scoring systems, such as the Piranha scoring system and the DiMaglio scoring system. If you have not logged into the previous CTEV video, please do now to understand more about these degrees and how to evaluate them before you move on with this video. Now, going back to the cast. So some authors would use the mnemonic of CAVE or CAVE to determine the appropriate method of correction. So some author would like you to mention the correction of CTEV by first focusing on cavus, then adductus, followed by the heel varus, and finally correcting the equinus. Actually, when you read most books, they will not put it this way because the correction of the CTEV case starts indeed with cavus, but the whole thing of adduction and varus, or in this case, it is mentioned as inversion, is done simultaneously. So you do not correct it one by one, but you correct it simultaneously. You do that by rotating the whole foot outwards in an abduction motion. Now, the way to do the cast, you can read it extensively in the global help files. You could download it for free. Once again, you could see it in the global help files, which could be downloaded for free. It is available in various languages. There you could also find how to place your hands on the foot during the casting. Now moving on, after you have achieved correction of the cavus, adductus, and also varus, last is you need to correct the equinus. Usually the equinus can be corrected even after performing a Achilles tenotomy, but sometimes Achilles tenotomy is always needed. So finally, you need to achieve equinus, but also improving the abduction and heel valgus. And the way you do it is same. You need to use talus as your axis, and then you need to perform maximum abduction and also ankle dorsiflexion. To achieve better dorsiflexion while you cast, you need to grab the heel or the calcaneus in this case, and try to put it down, while at the same time you need to apply pressure under the entire sole. Once again, you need to apply a pressure equally under the entire sole to achieve dorsiflexion, and not just the forefoot, because when you apply a dorsiflexion force under the forefoot, you will achieve a rocker bottom deformity, and this deformity is very difficult to treat. It is a very erroneous deformity, and this should not have happened if you have read the procedure carefully and you have do it carefully. Now, the last cast is usually done if the foot has already achieved sufficient abduction, and the equinus deformity itself usually is achieved to a degree of 15 to 30 degree for non-walking patient, but for an older patient, if you can achieve around 10 to 20 degree of dorsiflexion, then it is enough. So during your exams, for your board exams especially, you need to know what each of these casts do and what are the goals of each of these casts. And if you have mastered all of these goals, all of these degrees and numbers, then you are very unlikely to fail your exam. Next would be the Talectomy. This is the third step of the Ponseti method. The Talectomy is usually done during a very specific period of time. It is done when the Pirani score of the patient, the MFCS score, is less than 1, the HFCS score is more than 1, and the lateral head of talus is 0 or not palpable. The other thing about Talectomy is that it is done when the heel is still in neutral position and no longer in varus position. Keep that in mind because varus is bad. Neutral is acceptable. Slightly valgus, that is our goal. And you could see here that Talectomy, the technique is done usually starting from the skin prep, local anesthesia, followed by cutting the tendon, the Achilles tendon, completely, not partially. You could see here the technique that is being proposed and being given in the global health files. You could see there that the percutaneous sternotomy is usually done in the office, and the procedure includes giving local anesthetic and cutting through the whole Achilles tendon. You could see here that before the sternotomy, the dorsiflexion is at 0 degree, but after the sternotomy, there could be maximum dorsiflexion. You could see here that the examiner's hand is actually giving a dorsiflexion force. This hand right here is giving a dorsiflexion force at the entire sole. This prevents rocker bottom deformity because you do not apply it only at the forefoot. You give the force at the whole sole region. Okay, afterwards, you could start with bracing. The bracing is usually given at a very specific time frame with very specific goals. But generally, there are certain parameters that you would like to achieve. For the time frame itself, there are different tapering off period for brace that are worn at younger children and older children. But generally, the goals are the same. You need to wear a brace until you have reached the age of at least 5 years old. What differs between these two age groups is the different tapering off time. You could see here that usually when you brace a younger child, you start bracing under 9 months of age for at least 23 hours a day for the first 3 months, and then you gradually taper it off until only nighttime uses till the patient reaches the age of 4 or 5 years old. But for bracing an older children, you also need to brace until the age of 5, and the tapering off goes faster. So for most time, people wear around 16 to 18 hours a day. The child needs to wear them for at least 3 to 4 months before reducing it to nighttime use only for 12 hours a day until they reach the age of 5. But if the children started at above the age of 4 years old, then you only need to apply it partially or only at night time and for at least 1 year. That is when the child has reached age 5 years old. Okay, next it would be the position. You need to know that there are certain normal general position that is being used, which is 40 to 40 degree of abduction and 10 to 20 degree of dorsiflexion for the normal foot in cases with unilateral CTEV. But for the foot with CTEV that has been treated with the cast, you need to place it in a more abducted position, which is up to 70 degree of abduction and 10 to 20 degree of dorsiflexion. Now there are certain exclusion for these normal values, that is if the patient presents with bilateral clubfoot, unilateral clubfoot, atypical clubfoot, or those with associated defect. And you can see here in the global health guidelines that they have shown you clearly what are the goals that need to be achieved for each of those clubfoot. And you can read them and try to understand them. These are the general guidelines, but you do not need to memorize each and every one of them. You need to know what are the general acceptable values. Okay, moving on. After the bracing, you need to know that besides those basic treatment type that have been explained earlier, there are certain cases that still needs operative treatment. An operative treatment in CTEV consists of a large types of operations, but they usually consist of these 1, 2, 3, 4, 5 types of surgery. The first would be the soft tissue release, and the soft tissue release is of course indicated in resistant feet, sometimes rocker bottom deformity, and it is in a syndromic type of clubfoot with late presentation. And the technique is usually done at age 9 to 10 months old, and the structures that needs to be addressed include these structures. So basically all the tight structures, all the tight ligaments needs to be released, and all the tight tendons needs to be lengthened, and that is done to acquire the desired foot position. Next would be the bony procedure, which include medial column lengthening or lateral column shortening with or without cuboid decancellation. We could see here that there are various types of foot osteotomy that could be done. There is one proposed by the Evans. There is also the ones proposed by the Lichtblau, or also the cuboid decancellation technique. You could see here that each of these techniques have their own success rates. You could find journals associated with them, or just basically remember this picture inside your mind so that you know which part of the bone is actually cut when you do these procedures. And these procedures are usually indicated in older children of at least age 3 to 10 years old. Next would be the triple arthrodesis. Usually arthrodesis is reserved for a very severe clubfoot that has not been corrected until the age of at least 8 to 10 years old. Of course, it is contraindicated in conditions such as insensate foot, because insensate foot with triple arthrodesis equals disaster. You could see here that in triple arthrodesis, the incision is being done here laterally, and we could see here that there are wedges of bone that is being removed. The Now ficula, the calcaneal cuboid, then there is also the talocalcaneal wedges of bone that is being resected, and the goals here are to achieve a normally positioning foot. Okay, and the next would be talectomy. Usually talectomy means removing the whole foot, and the indications for doing this is the reverse from the contraindications of triple arthrodesis. You cannot do a triple arthrodesis on an insensate foot, and contradicting to that statement, talectomy can be done in an insensate foot, and usually it is also done in refractory cases of age at least 8 to 10 years old. Now, there are other techniques such as the multiplanar supramalleolar osteotomy. These are considered as a salvage procedure, and it is done in a complex cases that is rigid, and it allows multiplanar correction of the whole clubfoot by removing different wedges of bone from different areas of the bone. Okay, and finally, we will cover a little bit regarding the post-management program. You could see here that the Ponseti usually has a very high success rate, up to 90%, but sometimes complications do occur, such as recurrences. Why do clubfoot recur? Usually it is due to brace compliance. There has been several papers that predict the recurrences of the clubfoot based on the brace compliance, and it has found a significant correlation between the brace compliance and also the degree of the recurrency. Now, to prevent all those recurrence rate, you need to employ a strict bracing policy. You need to do daily gastrocnemius stretching before you put on the brace, and this could be done simply by the parents or by the children themselves. The parents could help by applying a dorsiflexion force, and the children could also do this by themselves by squatting down. Now, squatting is stretching all those posterior structures along with tibialis posterior. Now, physiotherapy might help but not always needed. Now, the types of recurrences itself, there are 3 types of recurrences that is frequently found, which is the varus recurrence, in which the heel can be seen still in a varus position, clearly seen when the standing child is being observed from the back. Treatment generally include manipulation and cast, followed by bracing, stretching, and physiotherapy. The next would be the equinus deformity. While slightly different from the varus, equinus deformity sometimes need another surgery followed by manipulation and casting before it could be treated well. The last would be dynamic supination. The terms dynamic means that the tibialis anterior muscles are very active, and during motion we could see that the foot returns to its supinated mark, and the treatment of this condition may sometimes include operative techniques such as tibialis anterior transfer, where the tibialis anterior is removed from its insertion and transferred to the dorsal aspect of the foot. Now, I will not cover the technique of the surgery for the tibialis anterior transfer here. You could look for it in your reference books, but generally what you do is you move the insertion of the tendon to the dorsal aspect of the foot, so that instead of supinating the foot, it assists in the correcting of the deformity. You could read up about this in various references, and the ones mentioned in the Global Health is quite good. You could also look up for it at the Tajian Pediatric textbooks. Now, last but not least, the surgical treatment for the CTEV does bring several complications such as residual cavus, pes planus, even under correction, in-toeing gait, osteonecrosis of the talus, and also dorsal bunion. That would be all for today's video regarding CTEV's complication and management plan. For more videos regarding the pediatric cases, you could log in and check out the pediatric playlist. Thank you for watching, and don't forget to subscribe to Orthopedic Tutor.